Subcommittee will come to order. First off, I appreciate the audience's patience given votes. We don't control the voting schedule, so thank you, and the witnesses. Without objection, all members have 5 days to submit statements, questions, extraneous materials for the record, subject to the length limitations in the rules. I will now make an opening statement and then turn it over to the ranking member for his opening statement. And I want to thank Mr. Yoho, my ranking member, for his longtime friendship and partnership in this issue. Also want to thank the members of the CDC and senior State Department officials for taking the time to come up here. Obviously, this is a very timely subject. This is our second hearing. A couple weeks ago, we had the first hearing in Congress on coronavirus, and this will be my second hearing. And I think about this issue based on my background as a physician, but more importantly, as the former chief medical officer for Sacramento County, who is in charge of the public health delivery system there, and as a faculty member in my last home institution was the University of California, Davis School of Medicine. The reason why I give that background is last night it became personal for me because it's hitting close to home. The first novel coronavirus case of potentially person-to-person non-transmission is in Sacramento County as we speak. That patient is housed at UC Davis, and I've been in communication with my former colleagues that are over there. There are a couple concerning issues that, as we go through the hearing, I'm going to want to ask questions about. But, if I think about this particular case, it initially arose in Solano County, which is close to where Travis Air Force Base is, one of the points of entry where we're quarantining patients as we evacuate them from overseas. Thus far, we don't know of this patient did not have any travel history, and we're not aware of any contact tracing. That work continues. The patient arrived at UC Davis last Wednesday or Thursday, was intubated at the time and on a ventilator. At that juncture, the doctors at UC Davis and the medical staff did not have a concrete diagnosis and had requested testing for coronavirus. It was determined that this patient did not fit the criteria for testing of coronavirus. This past Sunday, the doctors and the medical staff insisted on the test. A test was performed. Last night, we got the results back and the news that all of you have heard. This is the first patient testing positive where we don't have confident contact tracing. One thing that I will want to talk about, and perhaps with Dr. Redfield when we do our questioning, is the testing criteria. Also, the rapidity of getting testing capabilities quickly to every state, and the distribution of test kits. I was chatting with the ambassador from Korea earlier today. Korea is testing 15,000 people a day right now. So, whatever we can do to assist, our scientists to get testing capabilities up and running as quickly as possible. There's a couple areas that I would like to focus on in this hearing as well. I do applaud President Trump, although I think it was delayed in announcing and identifying someone as the head. He didn't use the term czar, but I'll use that term, who's the focus point to work across the interagency and who has direct access to the President and Vice President Trump. That said, I really do want to applaud Dr. Birx's appointment announcement. Very well qualified, and I think has our support. I also appreciate the administration's funding flexibility. I did think the initial amount of $2.5 billion was not going to be sufficient. I know the Senate suggested $8.5 billion. That may not be enough, and I think for this body in a bipartisan way, we should just be ready to make sure our scientists and the folks that are on the front line, particularly the folks that are in public health systems and hospitals on the front line, have the resources and support. Our number one job is protecting domestic national security. And at this juncture, while we don't know this rapidly evolving public health threat, we've got to be ready to make sure that our communities, our public health infrastructure, and our global health leadership has the funds and ability to do their job. In addition, as we are thinking about the dollar amount to appropriate, we have to do a quick assessment of public health infrastructure and assess the needs as well as the gaps. Having been in charge of a public health system in a large county, I know we run on shoestrings, and our infrastructure in a bad flu season would overwhelm our hospitals and emergency room capabilities, slap on potentially what we don't know how bad coronavirus will get. We just have to be prepared for the worst and hope for the best here. I also want to make sure, and talked about this with some of my colleagues on both sides of the aisle earlier this morning, we need to keep politics out of this. This has to be a nonpartisan effort. This has to be about looking at the science, following the facts, and doing what we have to do to keep the American public safe, but then also to focus in on the international community. That's going to be extremely important. In addition, we have to make sure, in this era where, it's easy to put out false information, we do have a very concerned public. We're all leaders as members of Congress and have the ability to communicate effectively. So the more we can coordinate with the CDC and others to get accurate information out there to make sure the public is accurately informed and that we can quickly dispel any misinformation will allow us to do our jobs and allow you to do your jobs and our scientists to do their jobs better. And lastly, this is the Foreign Affairs Committee, and global health security is something that we look very closely at. And in this sense, American leadership has to be central to how we approach this in a global aspect. So, Dr. Redfield, I'll be curious to get an update on how our scientists are doing, our CDC workers are doing in China, in the hot zone, if they've accommodated our workers. And we've got to have an international response, everyone working together in a transparent way, sharing information so we can get ahead of this. So again, I appreciate the witnesses for taking their time to come down here to inform us as members of Congress, but also to inform the general public on what is rapidly evolving here. And again, appreciate the members that are here. And with that, let me turn it over to Ranking Member Mr. Yoho for your opening statement.
Mr. Chairman, I appreciate those words, and this is like yesterday. It's deja vu all over again, right? We had the opportunity to meet with the Chief of Missions yesterday, and Chairman Bera opened up pretty much with the same thing about we're all on one team. This is Team America, and we have to work forward, and we have to be like a virus or a bacteria. We know no borders. We don't care what your political affiliation is. This is something we need to come together and make sure we have the right response for America. We had this meeting, this hearing 3 weeks ago, and you look around about the concern, because I think that speaks loudly with the attendance here for people to wait as long as they did. This is something that we need to be prepared for, and we want to make sure that we're in that. I'm a veterinarian by trade. We dealt with herd situations. That's not to mean we should treat people like animals, but we should make sure we put in the proper safeguards so that we protect our population. We have a bill that we have sponsored. It's called the One Health Bill, which coordinates animal diseases with human diseases, and this is why. 7 out of 10 human diseases originate with the animals. We've dealt with coronavirus for the last 30, 40 years in horses, cattle, dogs, cats, and other species, and so we know what viruses do. And I think the important thing that comes out of this, we lived through the Zika virus up here, and we saw the misinformation that was going out, the panic, the media, politics got put into that, and it was a disaster. What I've seen in this response is there's a level, kind of a calm, I don't want to say a calm, but there's more of a rational approach, and I hope we can do that in this hearing. I think will help this and help inform the American people. Other things that we're doing is this is appropriation seasons, and we're putting in appropriations for NIH, for NSF, for the research and development, but also for organizations like Gavi that does vaccinations around the world, and organizations like CEPI, the Coalition for Epidemic Preparedness. They're looking at the new and upcoming diseases to have vaccine models already ready for when something like this happens, because we can all rest assured this is not going to be the last time we're faced with something like this. And then I think the collaboration that we have with other countries, And we brought up the epidemiology last meeting that we had here. We had 2 epidemiologists, and we looked at the origin of where this was supposed to have come from in that province in Wuhan. And it was the fish market or fresh market. And we asked the epidemiologist if enough research was done, and they felt no, it hadn't, but yet the Chinese government came and removed that market. And so those start raising questions. And then you look at the amount of response, the severity of the response of the quarantines and people isolated. It sometimes doesn't match what we're looking at as the disease or what we're being told. It's not that severe, we can control it. But yet when you have, that province that was under quarantine, it's about 20% of the United States of America under quarantine. And then we've heard it's over 100 million people under quarantine. And what we want to make sure is that we have a measured, accurate response, and that we have a readiness that we're ready to respond to this in the appropriate ways. And I think so far what we have seen, I'm kind of proud of what our country has done. And I said our country, not an administration, but it was the country. And a lot of that comes from you guys here in this audience, and so we appreciate that. And then as I was talking about collaboration with other countries, we want to make sure no countries are excluded. Countries like Taiwan, that was so instrumental in the SARS epidemic, for a country like China to put pressure on other countries to exclude them from this process, in the WHO, World Health Assembly, or the WHO, I just think that's a wrong move. This is, again, viruses don't care what your political affiliation is. We need all hands on deck to deal with this. And so with that, Mr. Chairman, I'm going to yield back, and thank you.
Thank you to the ranking member. I'm very pleased to welcome our witnesses to today's hearing. We're joined by 4 excellent public servants. Jonathan Fritz serves as Deputy Assistant Secretary for the Bureau of East Asian and Pacific Affairs. He will be followed by Principal Deputy Assistant Secretary for the Bureau of Consular Affairs, Ian Brownlee. The final state witness will be Dr. William Waters, the Executive Director and Managing Director for Operational Medicine at the Bureau of Medical Services. Finally, we're honored to be joined by Dr. Robert Redfield, the Director of the Centers for Disease Control and Prevention. Please summarize your written statements to 5 minutes, and without objection, your prepared written statements will be made part of the record. Mr. Fritz, if you'd like to begin.
Thank you, Chairman Bera and Ranking Member Yoho. Thank you for the opportunity to testify today regarding the outbreak of the COVID-19 novel coronavirus and the Department of State's response. Throughout this global public health emergency, the Department has worked around the clock on what has always been mission number 1 for us, ensuring the safety and security of U.S. citizens abroad. The Secretary and his senior leadership team have been personally engaged in directing and supporting the U.S. response to this outbreak, in close consultation with our colleagues at the Department of Health and Human Services, including our CDC colleagues, at the Department of Homeland Security, the Department of Defense, and others. Utilizing their expertise, our diplomats and staff serving in the region executed evacuation plans, provided consular services, engaged foreign governments, and reported on economic issues arising from this outbreak. We simply could not have done so much to care for U.S. citizens and our own personnel in China without a department-wide effort. U.S. diplomats in China, Seoul, Tokyo, Phnom Penh, and elsewhere contributed to our evacuation efforts, ably aided by our locally employed staff, including those at our Consulate General in Wuhan. Throughout it all, we regularly engaged the People's Republic of China at the most senior levels, including President Trump's February 7th conversation with President Xi. Secretary Pompeo also spoke with his counterpart about the evacuations from Wuhan and stressed that protecting U.S. citizens in times of crisis is our number 1 priority. Our ambassador to China, Terry Branstad, worked directly with the Ministry of Foreign Affairs of China to facilitate evacuation flights and U.S. deliveries of donated assistance. Our team in China was on the ground, helping obtain permissions for our flights and processing passengers, operating in often difficult conditions. This work was instrumental in evacuating U.S. citizens and even some of our allies to safety. We faced challenges in evacuating U.S. citizens from the quarantine zone in China and additional complexities supporting U.S. citizens on cruise ships. The department worked closely with our allies in Japan to ensure the health and safety of U.S. citizens on board the Diamond Princess cruise ship docked in Yokohama. The U.S. Embassy Tokyo coordinated closely with the Japanese government, with Carnival Corporation, and CDC, and other components of the Department of Health and Human Services to assist U.S. citizens on the ship. After a high number of COVID-19 cases were identified, on board, and out of consideration for Japan's already overburdened health system, the Department of Health and Human Services made an assessment that the U.S. citizens and crew on board were at high risk of exposure and should be repatriated to minimize risks to their health going forward. In Cambodia, we organized response teams in Sihanoukville and Phnom Penh to assist U.S. citizens on the cruise ship Westerdam, working in close coordination with Holland America, Cambodian authorities, and the embassies of other countries with citizens on board the ship. Embassy teams included consular, medical, and logistics experts to facilitate health screenings, lodging, and travel needs of more than 600 U.S. citizen passengers. Our embassy also utilized its consular messaging platform and social media accounts to provide timely updates to passengers. In coordination with these efforts, USAID has provided an initial tranche of funding for affected and at-risk countries to address critical gaps in COVID-19 country readiness, including risk communication and community engagement, laboratory detection, enhanced surveillance, and infection prevention and control. In addition, USAID is arranging shipments of essential personal protective equipment to selected countries in coordination with the World Health Organization. Our efforts continue apace. We are continually engaging with host governments in the Asia-Pacific region to ensure they are informed of our policies and that we can share information and best practices to address this outbreak. We successfully encouraged Beijing to accept U.S. experts in the WHO mission to China. On February 7, 2020, the United States government announced that it is prepared to provide up to $100 million in existing funds to assist countries, including China, impacted by and at risk from the virus. Assistance to contain and combat COVID-19 will be provided bilaterally and through multilateral organizations. This commitment, along with the hundreds of millions generously donated by the American private sector, demonstrates strong U.S. leadership in response to the outbreak. Thank you, Mr. Chairman. I look forward to answering your questions and those of other members of the subcommittee.
Thank you, Mr. Fritz. Mr. Brownlee.
Chairman Bera, Ranking Member Yoho, thank you for the opportunity to testify today. The consular mission has always been the safety and security of U.S. citizens at home and abroad. We have worked in recent weeks hand in hand with our colleagues from the CDC, HHS ASPR, NIH, DHS, and others to provide critical information and travel alerts for U.S. citizens overseas, to help arrange repatriations of U.S. citizens from 2 countries, and to provide in-person consular services to U.S. citizens impacted by the outbreak in many other countries. In China, U.S. Embassy and consulate staff made thousands of phone calls and corresponded tirelessly via email and various online platforms to reach U.S. citizens in Hubei province. We worked with the Chinese government to help Chinese grandmothers accompany their U.S. citizen grandchildren on evacuation flights. As the Chinese government locked down Wuhan, our team in China coordinated with local authorities to allow U.S. citizens to travel to the airport to be evacuated. Using State Department chartered evacuation flights and working with our interagency partners such as HHS, CDC, and DoD, we brought approximately 800 U.S. citizens from Wuhan back to the United States. In Japan, U.S. Embassy staff created a dedicated web page for U.S. citizens quarantined on the cruise ship Diamond Princess and reached out to them individually by email and phone. As some U.S. citizens developed health problems, not all related to COVID-19, consular officers worked with Japanese hospitals to ensure U.S. patients received appropriate medical care. In collaboration with our interagency partners, the department transported over 300 U.S. citizens back to the United States on February 16th. We remain in close communication with Japanese authorities and the cruise line to assist those U.S. citizens who remained in Japan after the evacuation. In Cambodia, U.S. Embassy staff met the cruise ship Westerdam in the port city of Sihanoukville. Our staff coordinated Our staff provided key liaison roles, ensuring U.S. citizens were connected with the appropriate cruise ship authorities and Cambodian healthcare professionals. We also sent a team to the airport in Phnom Penh to provide consular services. Consular personnel in Kuala Lumpur, Karachi, and Amsterdam worked late into the night to help 91 of those stranded U.S. citizens get home last week. We are supporting U.S. public health authorities' efforts to contain the virus outside the United States. Visa officers have implemented Presidential Proclamation 9984, which suspends the entry into the United States of any aliens who are present in China, except Hong Kong and Macau, during the 14 days before any attempted entry into the United States. The Bureau of Consular Affairs is entirely fee-funded, and most of those fees come from visa applicants. Under our current authorities, we use these fees to cover most of the costs of providing services for U.S. citizens abroad, such as those I just described. However, based on what we now know, we anticipate a loss of approximately $98 million, a loss of $98 million in visa revenues this year as a result of COVID-19. To ensure we can help U.S. citizens in distress, despite falling visa revenues, I would ask that you grant the Department greater flexibility in spending existing fees. We remain committed to protecting the health and welfare of U.S. citizens overseas and working actively with the governments and international partners to achieve this goal in this crisis. Thank you, Mr. Chairman. I look forward to answering your questions of those of the other members of the subcommittee.
Thank you, Mr. Brownlee. Dr. Walters.
Chairman Bera, Ranking Member Yoho, and distinguished members of the subcommittee, thank you for the opportunity to testify today. As my colleagues have stated, the Department of State is committed to taking all necessary steps to protect the health of our overseas workforce and promote the well-being of U.S. citizens around the world. Between January 28, 2020 and February 16, 2020, the Department executed the most complex non-military evacuation of U.S. citizens in its history. The safe and efficient rescue of 1,174 people from Wuhan, China, and the Diamond Princess cruise ship in Japan is a testament to the agility, proficiency, and dedication of our workforce, our interagency partnerships, and others to accomplish our core mission, advancing the interests of the American people. Following the SARS outbreak of 2004, the U.S. Government Accountability Office recommended that the department work with interagency partners and the private sector to develop capabilities to support the medical evacuation and transportation of U.S. citizens from areas impacted by the sudden outbreak of infectious disease. And the 2014 Ebola virus disease outbreak again served as a reminder that the department must have a standing crisis response aviation capability to protect U.S. employees and citizens when emergency situations arise. Such a prompt repatriation of U.S. citizens from quarantined conditions could not have been possible had it not been for the Bureau of Medical Services' existing aviation contract and solid corporate partners. The MMAS contract is the department's only standing response aviation support and critical care medical evacuation capability, and the U.S. government's only standing biocontainment transport capability. Upon receipt of the mission directives, we managed to configure and simultaneously choreograph the movement of 5 aircraft, including the coordination of all flight clearances, overflights, and other required logistics. Department of State personnel on board these aircraft were trained and equipped to manage these operations. The department successfully directed and executed a total of 7 flights over 4 missions, with evacuees transported to 5 different locations within the United States, equipped to safely receive, evaluate, and house persons exposed to the virus. This operation involved close coordination with our interagency partners, including the Federal Aviation Administration and the Departments of Defense, Health and Human Services, Homeland Security, and others. We also coordinated with international partners, including the governments of the People's Republic of China, Japan, the Republic of Korea, and Canada. I was the lead medical service officer overseeing these missions and led the 2nd and 3rd mission on the ground in Wuhan. Some 41 countries and territories have reported cases of COVID-19 infection, placing the health of our employees and U.S. citizens in these countries and territories at risk. In these unprecedented times, the Department's medical professionals are committed to doing everything we can for the health and safety of our workforce and the U.S. citizens overseas. In summary, I'd like to thank each of you for your continued support as we keep pace with this international emergency. We know that your support to the Department, the Bureau of Medical Services in particular, has made this all possible, and that your continued support will be critical in the months and years to come. Thank you.
Thank you, Dr. Walters. Director Redfield.
Well, thank you, Chairman Bear and Ranking Member Yo and the members of the committee for the opportunity to speak to you today. CDC, the Department of Health and Human Services, the State Department, and other U.S. government partners are fully committed to confront the serious global health threat presented by coronavirus disease 19. CDC's public health approach to COVID-19 is built on decades of infectious disease expertise in prior public health emergencies such as SARS, MERS, Ebola, and pandemic influenza. Our goal is to keep America safe and to slow the introduction of this new virus into the United States. Our response involves multi-layered, aggressive containment, and potential mitigation measures as needed. These proven effective public health interventions include early diagnosis, isolation, and contact tracing. These public health interventions also include targeted travel restrictions as well as the use of quarantine for individuals returning from transmission hot zones such as Hubei Province, China, and the Diamond Princess cruise ship docked in Japan. Internationally, CDC is working with the World Health Organization and ministries of health across the globe to continue to combat this outbreak. CDC has deployed over 600 staff to the response, including staff supporting Japan, South Korea, and our country office in China. This outbreak underscores our national leadership role on the global scale and the necessity of strengthening our global capacity to stop disease threats at their source before they spread. When this outbreak was first reported in December 2019, China reported 27 cases of pneumonia linked to a seafood market. Today, there's more than 78,000 cases and over 2,700 deaths. Over the past 2 months, we've seen confirmed cases reported in 46 international locations, including the United States, and several of these countries now are reporting sustained community spread. In the United States, 15 cases have been confirmed by our nation's public health and medical community based on clinical guidance provided them by CDC. On February 26, CDC confirmed an infection with the virus caused by COVID-19 in a person who reportedly did not have any relevant travel history or exposure to other COVID patients. It's possible this could be an instance of community spread of COVID, which would be the first time this has happened in the United States. 3 cases have been detected among the Americans repatriated from Wuhan, and another 43 cases were confirmed among the cruise ship passengers that were repatriated from Japan. We commend the efforts of the government of Japan to institute quarantine measures on board the ship, and we appreciate Japan's cooperation with the United States government to evaluate and care and evacuate American citizens. CDC works in partnership with the State Department to assist in this repatriation effort of American citizens both from China and Japan. All of the individuals repatriated from Wuhan by the State Department charters have now been released from their mandatory quarantine. These individuals are not at risk of spreading the virus to others and should return to their normal lives. Passengers from the Diamond Princess are in the process of completing their quarantine at several locations across the United States. We are grateful to all the Americans who have and still are undergoing quarantine for their patience and their cooperation, as well as their willingness to ensure that they, their families, their communities, and our nation remain safe. We also want to thank the Department of Defense, the military personnel, their families on the installations where the evacuees have been quarantined for their hospitality and service to our nation. Efforts to direct flights from mainland China to 11 U.S. airports continue. CDC is working closely with Customs and Border Protection to screen arriving passengers from mainland China for illness and to identify people at high risk of exposure to this new virus and ensure that they were referred for the appropriate public health follow-up. To inform future travelers of the virus and where it's spreading, CDC continues to post travel advisories and alerts. Specifically, China and South Korea are now level 3 warnings that advise travelers against non-essential travel. Finally, CDC's current assessment into the United States is the risk of this infection remains low. However, we do anticipate new community cases. We have implemented a successful containment strategy, but we must be prepared to move to a blended containment mitigation approach. We also need to make sure we continue to strengthen our public health infrastructure, as alluded to by the chairman, and is ready for broader community spread. CDC and HHS will continue to keep members of Congress informed of new developments. We recognize that you are trusted leaders in your community, and communication with the public is essential during this emergency. Thank you, and I look forward to your questions.
Thank you, Director. I will now turn to my opening questions, and then I'll recognize the ranking member and our other members for 5 minutes for the purpose of questioning the witness. Director, in my opening statement, as well as you alluded to it in your opening statement, of this potential first patient of community spread. And it is in my home county, Sacramento County, at and the patient's housed at the hospital that I used to attend in and have taught lots of medical students in. You know, in talking to my colleagues earlier today and getting a sense of you know, the timeline of this patient, one thing is a bit concerning. You know, I've taken care of patients like this who get transferred up, who are intubated, who you don't have a sense of what the respiratory diagnosis is. You know, cultures are coming back negative, et cetera. And in this case, it does seem like last Wednesday, the medical staff asked for a test of coronavirus and were told this patient didn't meet the criteria and this was not a coronavirus patient. As the patient worsened, it does sound like this past Sunday, there's an insistence and a strong push, and ultimately the patient did get tested. And we know the results that came back 72 hours later as a positive test. A question that I'd have, and maybe it's twofold. Number one, what current criteria are we using to determine who's going to get a test and who's not going to get a test? You know, when a doctor caring for this patient and they're looking at a patient, they request that it's a no-brainer. We ought to do that test based on the medical expertise of the folks that are trying to confirm a diagnosis. At a minimum, with this new case, we ought to rethink what those criteria are, and I'd be curious to hear what criteria we're using today and if the CDC is updating that criteria. And then the second component is, you know, it is our testing capabilities seem a bit too slow at this juncture, and I'd be curious to hear what we're doing to increase the rapidity and availability of tests if we are getting testing kits out to all 50 states, as well as, you know, more broadly to you know, cities and others. And then, you know, it did take 72 hours from testing to get the results. And, you know, if we could get those testing facilities a little bit closer, I'd be curious to see how CDC is thinking about that. And I'm also told one of my sister institutions, UCSF, they've produced a more rapid test, need the ability to get some samples to confirm the specificity and sensitivity of that test. And there's some private sector companies that are also working on rapid diagnostic tools as well. So, Dr. Redfield.
Mr. Chairman, thank you for the questions. First, I think you know when this outbreak started, for better or worse, even in China, it was linked to whether you were exposed to the sea market, or food market. So obviously every confirmed case was from the market. And then when discussions I had with the Chinese CDC director, I suggested they go out and look at other people with flu-like illness, and of course then they reported that there were many cases that were not on the market. When the United States began this PUI, we had the epidemiological advantage of a link to Hubei initially, where most of the cases came from. Clearly, what's been demonstrated by the recent case is that's no longer operational. I will tell you that as soon as that case was recognized, we met and we revised our case definition for persons under investigation, and today that has been posted along with a new health advisory that the recommendation should be when a clinician or a public health individual suspects coronavirus, then we should be able to get a test for coronavirus. So that's the current guidance that went out today. This is a fluid situation. And your second question is also critical. How do we expand the availability of testing? We think it was an accomplishment to, within a week, to develop a test so we could get eyes on this, and I think the CDC scientists were able to do that. But that was not to take away the broader responsibility for the private sector to come in to be able to provide broader testing for the non-public health community. We've had aggressive discussions about how to expand that, and we are continuing. We have shipped our kits, as you know, initially out to many, many jurisdictions. We had trouble with one of the controls. That has now been corrected, and there are now 40 jurisdictions that have the ability to do the test modified with the FDA approval. And in the next, today, tomorrow, we anticipate more kits from the private sector that have been contracted by CDC to get out. And hopefully, our real goal is that LabCorp and Mayo Clinic and others, but you get at the root of it, why is there a difference? And I used to run a diagnostic lab and develop tests. The other countries have the ability for someone like me to develop a laboratory test and to deploy it. In our country, we develop a laboratory test and we need to go through a regulatory process in order to get it deployed. And again, I'm not criticizing the regulatory process. I'm just saying that's the difference. And many labs in this country, many hospitals could stand up, as you mentioned, San Francisco and other, your own, Davis could stand up a test within several days, because we've published the sequences and the methods and exactly how to do this. And that's how that one company, IDT, is now ready to sell a test, which is really basically a copy of the CDC test. So I do think we have to look at that, because this is an example where we were slowed, in a sense, because of the way we want to assure accuracy of these diagnostic tests. And I know you all are wrestling with that, but we are having more kits out later today that are going to be sent to the states. The state of California, I talked to your Secretary of Health just today, because they were down to 200 tests. We're sending more out there. There are 3 laboratories now, I'm told, in California that have the ability to do the test themselves. But both of your points are very, very important. We take them very seriously. One of least we're not going to let happen again, because we corrected it after the first case. And the other, we're working hard to get these tests out and hoping that the private sector comes in for the clinical use. CDC develops them for the public health use, and we need the private sector to come in for the clinical.
Director, I appreciate the change in the criteria and applaud that. I do think this is a unique situation where we need all hands on deck, and we do need to take a look at speeding up the regulatory process. We do need to allow the academics and those that have the ability to develop their own testing capabilities to quickly move through the process to make sure these are sensitive and specific and accurate diagnostic tests. And then if the private sector can augment our ability, especially now that there may be community spread, we've got to stop the bottleneck, and we've got to get these tests out to all parts of the country. So we can take that up here, but I do, looking at the administration, whatever we can do to speed up that regulatory process to make testing readily available to the practitioners that are out there. Yeah, with that, let me recognize the ranking member.
No, I appreciate it, and I appreciate y'all's testimony. And I think what you were just bringing up is a lot of the questions I had. I assume it's a PCR test or an ELISA test. Okay. The variation in those, you guys created that, and I think along that lines there should be provisional approvals quickly. And that's thing, if you guys are in a bottleneck where you can't get that, let us know so we can help relieve that, and then do the testing and verification down the road. But you have to have a place to start. And then when we get to the point where we have private manufacturing of these, we just need to make sure that we're all on the same page. It's the same test, so we don't have a variation in sensitivity or specificity, and that we need to make sure that the other countries are doing the same. My concern is, with so much of the APIs being created in China, about 85% plus is what I've heard, I look at it from a national security standpoint, or a national health standpoint. not just our country, but other countries. You know, if somebody needs Advil and you've got a population of 1.3 billion people, you know, are they going to service their customers first before over here? And I think this is a wake-up call for American manufacturers in our pharmaceutical countries not to be dependent on a country. What are your thoughts about that? Whoever wants to tackle that. Mr. Fritz, you're the one.
Thank you, Ranking Member Yoho. There's clearly going to be all sorts of economic impacts as the outbreak continues to develop. We are paying very, very close attention to not just the general macroeconomic impacts that are going to occur with regard to the United States economy and other economies around the world, but also to the impacts on supply chains, and particularly, as you mentioned, supply chains that are important to our ability to react to future instances, future outbreaks. I don't have anything that I can share with you right now, Ranking Member, in terms of what those responses will look like, but it is something that we're looking at very carefully. And we have people across the interagency process who are actively considering ways we can make sure that we are able to make sure that we do have access to the necessary supply chains.
All right. Let me ask about the cooperation. Do you guys feel that the cooperation is adequate with the Chinese government as far as transparency, just working side by side, or do you feel like it's here's the information we'll give you and kind of guarded?
Sir, why don't I take a first shot at that on, certainly with regards to the evacuation of our personnel and American citizens, very diplomatically and logistically challenging. I would have to say that we were able to achieve a very high level of coordination with the relevant Chinese authorities to make the 5 flights that we got into and out of Wuhan happen. They weren't easy, but we did, in fact, we were able to rely on our Chinese counterparts working with us to make sure that those succeeded.
Do you feel like they're treating all the countries that way? Because we heard the reports that they weren't letting the Taiwanese out.
I wouldn't be able to characterize whether they've been treating everyone as well as they've been treating us. I do know that they have worked well with a number of other partners, but I've heard the similar reports about our friends from Taiwan being treated differently with regard to their evacuation plans. I would say in general, however, I think the PRC authorities have generally made good faith efforts to help evacuate folks from Wuhan of other nationalities.
Does anybody have reports about this being in North Korea, which I would assume it is? I mean, do we have any definitive proof?
We don't have any confirmed reports. Yeah.
Okay. Let's see. I think with that, Mr. Chairman, I'm going to yield back, and I appreciate everybody here. I look forward to the questions, and I'm going to gather some more information. So thank you all, and you know, I know working together as you are, we will be prepared for this in the United States, and hopefully we can be the ones that help the other countries the most. Thank you.
Great. Gentleman from Michigan, Mr. Levin's recognized to question the witness for 5 minutes.
Thank you, Mr. Chairman. On Tuesday, Nancy Masonier, the director of the National Center for Immunization and Respiratory Diseases at the CDC, said this of coronavirus. Ultimately, we expect we will see community spread in the United States. It's not a question of if this will happen, but when this will happen, and how many people in this country will have severe illnesses. But National Economic Council Director Larry Kudlow then said, we have contained this. I won't say it's airtight, but it's pretty close to airtight, end quote. And also, this is all on Tuesday, President Trump said of the coronavirus in the United States, quote, that it's under control and a, quote, problem that's going to go away. So that was all on the same day. Americans are scared of this situation, and they want to know what's being done to keep them safe. And hearing mixed messages like this within the span of hours isn't reassuring. Dr. Redfield, how can the virus be both a problem that's going away and also not a question of if, but when? What should we be telling our constituents about what to expect?
Thank you very much. I think it's a very, very important question. Right now at this stage, and I've said this and I continue to say it, the risk to the American public is low. We have an aggressive containment strategy that really has worked up to this time, 15 cases in the United States. Until the case that we just had in Sacramento, we hadn't had a new case in 2 weeks. We do believe we're going to continue to see new cases, and we do believe now there may be the initial cluster or occurrence of a community acquisition. Some countries, this has moved very quickly, like we saw in Korea now, where we had more cases in Korea in the last 24 hours than we had in all China. Right. We see it in Italy, it's moving fast. Iran, it's moving fast. But other countries have really used a containment and a blended mitigation strategy like Singapore and Hong Kong, and they've really limited the spread after the initial introduction from China. We're of the point of view that we're still in aggressive containment mode, which is dependent on early case recognition, isolation, and contact tracing, that now is going to be looking to identify these community introductions and practice public health to minimize them. But at the same time, we've done this to give us time, and I think what Dr. Messonnier was trying to say, I think it was maybe could have been done much more articulately from what the American public heard, was she was trying to say it's also a good time for us to prepare if we have to go to more mitigation. We're still committed aggressively to get aggressive containment. And I think I want the American public to know at this point that the risk is low. I want them to know that we are going to start identifying more cases like we did the other day. I'm going to ask them to obviously accelerate their own view of the standard things that we do for flu, hand washing, cough in your sleeve, don't go to work or school if you're sick. And we have launched a larger, for our next level of our multi-layered public health response, is to now institute broad surveillance. And we've initiated it. We're planning over the, hopefully the next 4-8 weeks, obviously linked to the supplemental, to actually make our surveillance system for corona the same as flu, nationwide. So we can be, very quickly picking up when there is an introduction in a community, go in and try to stop it. So I think that's our position at this point.
Good. Well, let me quickly ask you one other question in my limited time. I want to ask you to speak about the danger of xenophobia in a situation like this. CNN reported last month on disturbing example from the SARS outbreak when, and quoting them, people of Asian descent were treated like pariahs in the West. There were reports of white people covering their faces in the presence of Asian coworkers and real estate agents who were told not to serve Asian clients, end quote. We saw similar incidents during the H1N1 swine flu outbreak in 2009 and during the 2014 Ebola outbreak. And sadly, I've heard reports of incidents like this around coronavirus. So I'd like you to talk about why it's so important to avoid stereotyping people as carriers of the coronavirus and how incidents like these can be avoided and how they're dangerous really for public health.
I couldn't agree with you more. For those who've heard me talk before, I've always said that stigma is the enemy of public health in all its forms, whether it's in dealing with HIV, whether it's dealing with drug use disorder, whether it's dealing with obesity, whether it's dealing with a response to the coronavirus at this time. Stigma has no role, no place in public health. It's counterproductive.
So I think we're going to have to proactively get that message out to the American people so that we don't harm our own public health with stereotypes folks might have. Don't you agree?
Yeah, I will continue to echo it, and I think you make an important point because we have seen those reports, and I think, again, we need to re-echo that stigma has no role in public health.
Thank you, and thank you, Mr. Chairman. I yield back.
Thank you. The gentleman from Florida, Mr. Mass, is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Redfield, I want to start with you, and you spoke specifically about early diagnosis being part of the positive that's going on here. Can you discuss with me what are early symptoms which lead to early diagnosis?
I think the first thing I want to say is there's a lot we don't know, and we're learning more each day. That's what concerns those of us that are confronting this. If it was flu, we understand flu. but there's a lot we don't know. But what we have learned in the last 8 weeks is that this virus can actually cause asymptomatic infection. No symptoms. Now, that's complicated when you're dealing with a public health threat, if you can have it. And on the Princess ship, over 50% of the individuals that were diagnosed in the process in Japan lack symptoms. Now, there may be an ascertainment issue because they thought if they had symptoms, they'd be treated different. But clearly, there's a significant percentage of people that lack symptoms. And there's clear evidence now that we've learned those individuals can actually transmit the virus. So as the chairman knows, from a public health point of view, that makes this more complicated. The other side of it, its symptoms can be as negligible as a scratchy throat, a dry cough. And you can see that's why initially we had PUI definitions that were pretty narrow, because if all of a sudden everybody with a scratchy throat or a dry cough during flu season came, then we had some perplexities. At the severe end, it can cause really a very significant pneumonia, respiratory compromise, requiring critical care. And overall, it does look like 5% of individuals in the China situation are critical, 15 need critical care. Other countries are starting to show similar. But on the other spectrum, there can be this asymptomatic illness. So we're still learning. It's complicated. Obviously, in the individual case that we talked about here, where severe pneumonia in an otherwise healthy individual, in light of what we now know, that can prompt the medical community to consider the coronavirus in the differential diagnosis. But a lot of individuals may just present with a sore throat and a dry cough.
Let me go to the other side of the table. 80+ thousand cases diagnosed, and the number that I've read is 33,000 recovered in mainland China, recovered from having the diagnosis. Can you say what has been a chief factor that has led to those that have recovered through it? Is that something that we know?
I think there's probably two major factors. One, or maybe three. One is age, and one is comorbidities. So individuals that happen to have diabetes or hypertension or chronic obstructive lung disease and happen to be elderly, these individuals have a much higher mortality. But the other issue that needs to be stressed is the effectiveness of the healthcare system. So in Wuhan, the mortality right now is somewhere over 4%. Their health system is beyond strained. Before this outbreak, they had 132, I think, isolation beds for infectious disease. Today, they have over 20,000. Now, you can go from 132 beds to 20,000. You can build the structures. But as the chairman knows, where are the doctors? Where are the nurses? Where are the ventilators? Where is the trained healthcare professional? So we see a mortality, and we believe it's the integrity of the health system that is a major factor, because if you just go to the rest of